Good evening, everyone. I'm Paul Bozyk. For those that don't know me, I am a pulmonary intensivist, and I am from Oakland County, proud member of my county organization and chair of the board of directors of MSMS. It's an honor and a privilege to represent this board tonight. I do want to thank all of you for taking time out of your busy schedules to be here for these important discussions as we work through Ways and Means tonight and other reference committee works as we move forward, culminating in our House of Delegates on April 18th. Um, and I want to thank the board for everything that they've done. It's been a tremendously busy year. I'm going to give you highlights of some of the things that this organization has accomplished, and I think you'll be very impressed. Could we go to the first slide? It's interesting. We've previously sent member surveys saying what's important to you in organized medicine. And this organization, the State Medical Society, is really focused on advocacy, practice sustainability, healthcare delivery, and education. And I'd like to share some of those successes with you briefly. I mean, from our government relations standpoint, MSMS advocates on behalf of physicians and their patients by engaging lawmakers to ensure health policy reflects clinical expertise and patient-centered care. Look at the accomplishments. We've monitored 354 bills. The state societies provided testimony 26 times, nearly 5,000 advocacy emails, 28 physicians participating in Advocacy Day, which was outstanding, and 78 legislative meetings. This is a unique competency of this state medical society, and we need the state medical society to continue advocating on our behalf in this regard. And how have we done that? Next slide, please. You remember that MSMS took the lead in defeating legislation to weaken our professional liability laws. That was last year's lame duck. And against that lame duck, we were able to avoid a 38% increase in liability rates. Staggering to any practice, staggering to health systems. And MSMS was able to accomplish that, which is a great victory. But what's before us now? Next slide, please. We're working very hard at the State Medical Society to focus on scope of practice. So long as there are physicians in the state of Michigan, there's going to be a need to watch scope of practice. So this session, both nurse practitioners and physician assistants have billed to allow independent practice. MSMS is at the center of these hearings, lobbying the legislature, and our advocacy staff has so much experience, over 70 years of combined experience in doing this. And this is a battle we've continued to fight, and our strategy has been sound thus far. We have a multi-client lobby firm that has very deep roots with Michigan State Medical Society, and their CEO is a former MSMS staff and has worked on physician issues for 40 years. And we have our CEO, and we have the benefit of his legislative expertise as a former legislator himself. So this is a unique competency again of our State Medical Society. You see the QR code before you. Please don't leave tonight. Don't leave the slide. I'll talk for a little bit longer to give you time to take out your phone, to click on that and see the advocacy alerts that are going to go directly to your legislators through the MSMS Action Center. Next slide, please. And very exciting, MSMS authored new legislation that would decrease CME burden from 150 hours to 75 hours every 3 years, and would require a review of the mandated topics, which many would disagree with. It also sunsets administrative errors, which can happen after 7 years, so that a physician isn't adversely affected or penalized for administrative errors, and also creating transparency and fairness in any investigative process that would take place in the review of someone's CME. And again, MSMS authored this. This is another unique competency of what the state medical society can do in terms of advocacy on behalf of Michigan physicians. But we also do a lot in the healthcare delivery space. Next slide, please. Um, MSMS has advanced physician interests through multiple facets, advocacy, collaboration, and direct support on payer, legal, and regulatory issues. 12 letters were submitted to federal and state legislators and regulators on Medicare payment, Medicaid funding, telehealth, which looks like, according to the AMA, that's getting refunded, which is good for the next 2 years, according to an email from Bobby McCumilla as AMA president that I received last night. Physician-owned hospitals, downcoding policies, out-of-network care, substance use disorder, ACA premium tax credits, immunizations, and medical loans. And over 20 meetings with insurers, 20 meetings with insurers, including all of those you see before you, to make sure that we have no interruptions in efficient healthcare delivery. Next slide, please. We've got tremendous state medical society engagement in collaborative partnerships with CPAN, Coalition of State Medical Associations, Protect Michigan Care Coalition, Michigan Alliance for Legal Reform, all these that you see in front of you right now. And we've submitted legal alerts. What do physicians need to know about immigration enforcement? I remember that when that alert first came out, creditors' rights for medical practices following bankruptcy, and an updated MSMS HIPAA guide. And next slide, please. I presume that everyone on this call has heard about threats to Modifier 25 and its compensation. Blue Cross Blue Shield announced a new policy that would eliminate the use of Modifier 25 in many cases, or have a significant cost reduction in the E&M, 50%, if Modifier 25 is attached. And once again, the State Medical Society has driven to seek a coalition of like-minded physician groups, and put this back to Blue Cross and Blue Shield to rescind this policy, to rescind it. So the coalition has been organized. There's a letter, very comprehensive. I think there was 27 different groups that signed on to that letter. There could have been more, but we wanted a prompt, an efficient reply to Blue Cross Blue Shield with the pointed ask to meet and rescind this policy. And a second joint letter was sent with 29 specialties and co-signers. Of course, this was all in collaboration with our ex officio MSMS board members that sit on the Blue Cross and Blue Shield board. They don't have to put us on their board, but because of the strength of the State Medical Society, we get members on that board. And you may have seen in social media examples of how this is going to impact independent practices. AMA has been involved in this through contact with the State Medical Society for counsel on how E&M reimbursement would play out, and how other states have successfully fought this. Trying to keep everyone engaged. Hopefully this group is aware of everything coming out in Metagram articles. And we look forward to scheduling time with Blue Cross Blue Shield physician leadership. Again, a tremendous effort from the Michigan State Medical Society team. Next slide, please. We had 5 new legal alerts in the past year that were reported out by Michigan State Medical Society related to accessing federal health data and guidance and webinars series, the BCBSA settlement update and webinars, the tipped wages and sick time, what practices need to know regarding ICE and creditors' rights for practices. And there's additional resources, of course, always available on the website. I should say, new website. If you haven't been there, it launched about a week ago, and the organization is superb. So please go there to see what it's like. And while you're there, check out all of these resources that you can find on the website provided by Michigan State Medical Society. Next slide, please. This one came from Dr. George himself. He discovered this multi-plan litigation that was going on. You remember that multi-plan was this group that processes out-of-network claims for commercial insurance companies. And then they use pooled pricing index to fix prices and lower payments, and then they profited from underpaying for those services. And through outreach from MSMS to the physicians of Michigan, MSMS got thousands of physicians to join the suit and seek compensation for underpayment. Thank you, Dr. George, and thanks for the staff and team that enabled this to occur. Next slide, please. Uh, so CME. You know that CME from MSMS is all education is free to its members. It's free to its members, and boy, the members are sure using it. We have folks that are attending, hundreds that are attending in-person conferences, hundreds more that are participating in live virtual conferences, and over 6,300 docs that are completing CME through one of 120 on-demand webinars. And if you haven't gone to the education site, it is worth going to. You will find the state mandated education there. And the full list of courses is what you see before you at msms.org at education. And I'm going to pause for just a second because I've talked about a lot of victories. I've talked about a lot of wins by a small and shrinking staff, as Dr. Waters brought before you. At peak of the society had 154 employees. 154 employees. We are down to 20. And of those 20, 9 work for the subsidiaries, which means that 11 work for MSMS, and in the role of advocacy, education, the things I've discussed, healthcare delivery, practice sustainability. And so a tip of the cap and congratulations to the staff for everything that they've accomplished with limited resources. They've dug in their heels, and we couldn't be more proud of what they're accomplishing. Despite that, next slide, please. As Dr. Waters alluded to, and as you see in your Ways and Means packet, which I would read carefully and look at the graphs and look at the trend lines. Over the last 2 decades, MS has experienced significant decline in not only the number of active members, with a decrease that's unfortunately accelerating. And I will share with you tonight something that we discussed in our board meeting yesterday. That decline looks to persist into 2026 as we look at the trend line. And a 60% decrease in dues revenues, and then I discussed the staffing situation. Next slide, please. Well, that slide's out of place. Next slide. So what we do have is a financial statement audit that shows that what these losses are attributed to are not issues with internal bookkeeping within the state medical society. MSMS undergoes a financial statement audit every year by an independent firm. We use Maynor, and they're there to make sure that we have good structure that would also avoid the opportunity for there to be any sort of financial malfeasance. And MSMS has been found to meet these accounting infrastructures, internal controls, and financial requirements, and has passed every audit for at least the past 3 decades. Might be just a hair under that. I think it's been since 1997 that we have records of audit keeping. And in in your packet, you will see the full audited financials that are included in the annual financial report to the HOD every year. Next slide, please. I'd like to talk a little bit about task force reorganization as I transition off of those financial reality slides based on the things that Dr. Ghosh and Dr. Wise and Dr. Waters all mentioned. We had multiple House of Delegate resolutions that were referred to the board. And these were treated like any other resolution referred to the board. We've got a process. If we've got a committee that's standing that can address the referral to the board, then that committee takes place. This did not. This was a larger strategical task, and so the MSMS Board of Directors appointed a reorganization task force to provide recommendations on three major structural areas within MSMS related to the House of Delegates, related to MSMS's relationship with its organizational partners, including county medical societies, special medical societies, and physician organizations. And then asked to look at ourselves related to things like the board of directors themselves and the officers and judicial commission. Next slide, please. The task force met 4 times from August through January, which doesn't sound like much, but there was extensive conversation between meetings, and we got homework because one of the things that the referred resolutions asked us to do is look out for other states. Let's see what they're doing. Let's see what their experience has been. So we received that input, and the task force was provided with it with time for thoughtful consideration before these meetings. So extensive review and deliberation. The task force unanimously recommended a series of comprehensive structural changes designed to position MSMS for the next decade of success, trying to live up to the standard of the resolution that said future proof, right? The task force language was that these 4 recommendations are interdependent. They rely upon one another. So they're, from the task force's point of view, they were intended to be adopted as a unified reform plan rather than individually. However, we understand that the complexity of these changes doesn't lend well to having them all taken up as one item before the House of Delegates. So we've broken them down into 4 board action reports, despite the fact that the task force recommendations, again, are that these all should be voted together. Next slide, please. I'll just go through what you're probably aware of already, which are the 4 recommendations from the task force that went to from the task force to the board, and the board adopted the recommendations of the task force. That's what you see before you. So now the owners of these recommendations are the board of directors who have recommended again that these go forward. So first is replacing the House of Delegates with an all MSMS member online policy forum. There's also a separate resolution that you'll see coming before you that asks for this. It asks for it. And why would we do this? It's going to extend participation to all members rather than the 2% of members who are currently represented in the House of Delegates, when we usually annually get approximately 100 members to come. And this would be a way to improve actually democratic decision making across the entirety of the membership while improving efficiency and inclusivity, because we can leverage technology now to have a continuous year-round policy committee that receives resolutions electronically at any time of the year. And what does this do? Well, first of all, cost savings is incredibly important to the State Medical Society at the moment, given the financial trends that have been described. But it's going to reduce direct costs by $60,000, which is the approximate cost for the one-day meeting in Lansing. But there's significant indirect staff time that surrounds the House of Delegates when it comes to policy preparations and organization of the reference committees. So doing this would, I use the analogy, instead of the bolus model on staff, we'd get the drip, we'd get the continuous drip, so that they're not overwhelmed. Because this is a good example of a very busy time for the medical society because they're actively working on those things like our scope of practice bills and holding off the NPs and the PAs, and the CME is active, and many other things. And the staff is very busy also with the House of Delegates and Reference Committee preparation. Next slide, please. County medical societies. So the recommendation was to eliminate the mandatory dual membership and chartering of our county medical societies. This is a tough one. I will tell you that I have already promised my county executive director, Romy Shubatowski, I will always be a member of Oakland County, so long as I qualify as a member. I don't plan on moving, so hopefully I can be a member for a long time. Just like having grown up in the House of Delegates, I've grown up in the county medical societies, having been a member of three great medical societies in Wayne, Washtenaw, now Oakland. There are other great county medical societies as well. However, at the state medical society level, it's incredibly challenging to look for large group members, especially if they have any geography to them, because then we have variability in cost per county, or membership benefits. And so if you're looking at large organizations, they're saying, well, why is Dr. A this much and Dr. B, who lives over a county line but 3 miles away, this much? This reduces the administrative complexity significantly. There are over 2,000, actually, 2,300 different dues combinations. We've been talking about this for years in the membership committee. And MSMS gets it. That's because we have different dues structures also. But when you multiply them out times all the different county structures, it comes up to 2,300, which would never be a capture of a large group with that sort of complexity. It does modernize the membership to reflect the realities of modern medical practice. We have doctors that work in more than one county. We have doctors that work in more than one area. And it does align with the resolutions asked us to look to legal. We did. Legal counsel's findings was that the dual membership model may pose risk for MSMS and the county medical societies. And I'm just going to stay here for just a second, because I want to talk about that. And in some of the prior iterations of the frequently asked question docs, you may see that we have 13 counties. They're charging dues, but they're giving membership benefits, and they're all, engaging with the physicians in that community. There are 11 that collect the dues but are not engaging with the members of that community. And so that's a difficult sell for a state medical society to say you must belong to one of those counties, despite the fact that they don't have membership benefits for the dues that are owed. And that's just one of the potential risks that exists in the current structure. Next slide, please. The Judicial Commission is relatively straightforward. The recommendation is to eliminate Judicial Commission and requirement for county medical societies to maintain a peer review and an ethics committee. And this is a structure that many folks who are members may not know about, but remotely, a century ago, Michigan State Medical Society would be the one to oversee questionable practice by physicians. And it would start at a county level, and the county's peer review and ethics committee would send it then up to the state judicial committee. However, this was well before the time of our medical boards of medicine and osteopathy, and which is where these things should be going. And suffice it to say that many counties don't have a distinct peer review and ethics committee, though I understand some counties use their board for that. But the state medical society certainly hasn't been able to maintain a judicial commission. So we see this as something that's a vestige of times gone by. Next slide, please. The last recommendation relates to the board of directors and reducing the size. This came from the task force to the board. And the board said, we agree with the task force that the MSMS board of directors should be reduced from 36 to 13 members focused on skill-based rather than representational government. This reflects nonprofit best practices for associations under 3 million in revenue, similar to MSMS. This came from outside experts that publish on this. I'll mention that the Texas Medical Society has over 60,000 members. 60,000 members. MSMS has dropped under 4,000 active members. Texas Medical Society has a board of trustees with 12 voting members on it for a membership of 60,000. So the hope is that this is going to promote strategic decision making, grounded in financial, organizational, and physician leadership expertise. Um, and I'm sorry, and there's a lot of question about geography. It's a lot of question about geography, and I understand that. And so there would be hope for differences in, diversity in geography as well. And I think that would, um, play to the type of practice that someone may be in. A rural experience may be different from an inner city experience. And I think it's important to have all those voices on the board of directors. Next slide, please. So we've had membership losses. We lost 53 groups in the last 5 years, 17 in 2025. Um, More coming, and I think this list has maybe even expanded since the time of the slide's creation, that have not renewed yet. Doesn't mean we're not still pursuing them. Um, but it looks like the trajectory again is going to continue downward as far as membership size would be, which is consistent with what Dr. Waters told you in 4 to 6 years. Losses year over year like this are going to make us a very small organization. And under current bylaws, every loss of a state medical society member is the loss of a county medical society member. So we're all contracting, and none of us want that. Next slide, please. However, there's some hope. A very busy, active membership team from Michigan State Medical Society over the past 3 years met with 70 groups, 70 different groups. You can see some of there on the right. This is 13,000 plus physicians. And the word from these groups, the feedback received to the membership team is that it's cost prohibitive. Cost prohibitive in part, if not whole, by a mandatory dual membership, um, which is challenging to swallow, but that's the feedback we're receiving from our would-be members. Next slide, please. So I'm gonna I'm gonna do something awkward. And I think we had a slide out of place that I'd like to show you. And so, Rebecca, let's do it right, and we'll back up to that one slide. There we go. Membership leads. I showed you those 13,000 plus doctors. If we could convert 5% of leads to members, that would strengthen the foundation of the state medical society to an estimated $656,800. And the membership staff thinks that this is a conservative estimate. And wouldn't it be great to have the power of, approaching Texas Medical Association or California Medical Association, some of our strongest state medical societies in the country, by having some creative membership opportunities for some of our larger groups. So eliminating the county dues allows MSMS that flexibility to research, to pilot, and implement other dues models outside of individual membership. Um, and I'm gonna also pause here for a second because we talk about group membership a lot, and that's because of the transition to more employed docs that exist. But I'm going to pause for just a second and say, we stand on the shoulders of our independent practices because they have been loyal members of MSMS, from the beginning, and so greatly value their contribution to the medical society. Okay, Rebecca, if you could take me forward, please. So I've showed everything, not everything. I've showed you highlights of what a small but mighty staff for MSMS can be and what they've accomplished for us. And we've seen the trajectories. We've seen that the dues are decreasing, the membership is decreasing, and this isn't a one-time thing. As Dr. Waters mentioned, this has been going on for a couple decades, unfortunately. Um, but we're concerned that if we continue doing business as usual, then we're going to see that 1,000 member organization in 4 to 6 weeks. And all of the great people that are doing all of the great things are not going to be part of the organization. The organization could not sustain it. We can barely sustain the work with staff. We're doing an incredible job once again, given the things that the task force committee has identified and are trying to optimize. So we don't want to lose that legislative activity. Scope is going to be an every year fight, right? Med-Mal has come up and we swatted it away. Prior authorization, everyone remembers Health Can't Wait. Look at what we're doing with Modifier 25 and Blue Cross Blue Shield at the moment at the State Medical Society, and payer advocacy important. Dr. Ghosh mentioned Medicaid earlier in his address, and then regulatory advocacy, always very engaged. There's two cases going to the Supreme Court right now that could have direct impact on our practices and medical malpractice. What about licensure? And then all the free CME. We don't want to see that go away. Um, Next slide, please. So think about these things. You're going to hear a lot in Reference Committee C. It's a tough pill to swallow, some of these recommendations, and I get it. I was born in the House of Delegates and had three great counties that I will continue to participate in. And so it's hard. But I can't let my feelings impact the facts, and the facts are before you, and they will be discussed again at reference committee. They're in the reports. Please look at the reports because the board is advising that we pass all four recommendations. And so with that, one last salute to the staff who's been so incredible in those first few slides, are really very positive. This part, I don't want to end on a negative. So thank you to the staff for everything that we're doing, and please vote yes for the four recommendations of the task force that have been approved by the board. Thank you very much.